Okay, so like I said, we're doing neuro, talking about spinal cord injury. And I know you haven't finished going over it, so hopefully this will give you a jump start in your class, so that you'll be able to learn more specifics rather than learning all from scratch starting when you have it. Okay, so just to give some background, just to make it more understandable, this cloud is your brain, okay, and this is your spinal cord. Right now, there's two nerves do two different things, right? They provide sensory input and motor input or output, I should say. Like I touch this table, I can feel it because of nerves, so that's sensory. So you have, let's say someone's hand, and you have a match and fire, right? So sensory goes up the brain, so that's would be called a afferent with an A. They also call it ascending because it's going up the brain, like the input's going from wherever the stimulus is going up. Does that make sense? I think AA, ascending or afferent for sensory, and then like let's say you have your other hand over here, and you're using your hand to, this is a pencil, to write, so it's motor, right? So this one is called efferent. I think E for like exit, like it's exiting the brain because it has to start in the brain. You decide, even if you don't think about thinking about it, you think about I'm going to move my hands, and then that it happens really fast, but it starts up in the brain, goes down the spinal cord to make motor happen. So efferent or descending. Does that make sense? So that's what we're talking about when we talk about nervous system. The other thing, wow, this glare is really horrible for this video, but you know, I don't really know what to do about it. So it is what it is. Erase this. You're gonna have to know the numbers for the spinal cord. So quickly just do that. And so this is roughly what the spine, I mean, obviously it's not this pronounced, but there's curves. And it's split into sections like this. Generally, the first part is cervical. And do you know how many nerves are in it? 8. And then the next one is thoracic. And do you know how many nerves? 12. Lumbar and sacral. And do you know how much each of those have? 5. Yeah, 5 each. I don't know if they taught you this or not, but like the easy way to remember is breakfast, lunch, dinner, 8, 12, and 5. The other thing they're probably gonna want you to know is what it innervates or what, you know, it controls. So cervical is gonna be head and neck. Oh, this pen is dying. Head, neck, diaphragm is the big one, and that's probably going to be a test question. Diaphragm is the big thing with the cervical. If you have people have C injuries, respiratory complications are the biggest thing. People don't think spine relates to respiratory, but that's the big one. And then also shoulders and arms. So one way to test, you know, test the nerves is like shrugging your shoulders, lifting your arms. That helps test how far down that injury is, because obviously the higher up the injury is, it's going to be worse, right? Because it's everything below the injury is going to be affected, right? So if it's down here, you might still be able to have control over your diaphragm, because that's C3, 4, and 5. C3, 4, and 5 keeps the diaphragm alive. It rhymes. So if you only hurt like C8, maybe you just can't shrug, but you can still breathe. So that's good. Okay, thoracic. Do you know what this one innervates? Yeah, chest, abdomen, and GI. So why that matters is what's in your abdomen? In the guts. Yeah, like your intestines. So if this gets messed up, you could have some GI complications. You know, peristalsis is really important. to maintain GI motility, passage of stool. So some complications could be like compaction, constipation, poop just like not coming out, an ileus even. So those aren't good. Okay, then lumbar and sacral. What about these? Yeah, so your legs, obviously. And the big one for sacral is bowel and bladder. I'm just going to put B/B. That's going to be bowel and bladder from now on. And then sexual function. So erection, orgasm, those sorts of things that gets affected by the sacral. So you can imagine, obviously you don't want to have an injury at any point in your spinal cord, but the lower the better, because you retain function of everything above where the injury is. So we'll leave this up for a little bit. We can look at it for a second. Do you know the main causes of spinal cord injury? You just think about it. Okay, what would most likely cause someone to sever their spine? Biggest one is car accidents, because just big impact. A lot of people, that's how they become paraplegic, quadriplegic, either getting struck by a car or being in a collision. The other ones are falls, especially with older people. So in hospital we have like fall risk protocols, especially for the older ones. I mean, hip fractures are a big part of falls too, but we also want to protect the spines. And then you see a lot of these in like inner cities. You'll see like gunshot wounds, bullet to the spine generally isn't good. Same thing with knife stabbings and gunshot wounds to the spine. And then lastly, it's just sports. So some sports obviously are going to have more risk than others. Contact sports like football, even actually cheerleading. People don't think so, but like, cheerleading does a lot of gymnastics, like spins and flips and stuff. So that's one of the highest actually injury prone sports is cheerleading. So that's that. And then so there's different types of spinal cord injuries. Quickly go over those. Pretty self-explanatory. So hyperflexion. I had this happen to me. Hyperflexion is when your neck goes chin to chest like this. So you're just hyperflexing the neck. And I was on the gym masters team when I was in school, and I did a double front flip and forgot where I was in the air, and I was supposed to land on my feet, but I freaked out somehow and actually landed like on my neck on the mat. So like I landed like right here, and it drove my chin to my chest, and I felt it crack literally every single vertebra from up here all the way down, and I just laid there and I was like, oh God, I'm paralyzed. This is how it ends for me. Like I was convinced, right? Because I was like, you don't fall from this height and feel every single thing crack and be fine. You don't walk away from it. I'm fine, obviously, miracle. Yeah, I still have like neck pains and stuff from that, but that would be an example of hyperflexion. In a car accident, you see these most in head-on collisions. So like if I'm going forward, at 60 miles an hour, and I stop suddenly because someone hits me in the front, your momentum carries you forward and your chin snaps down. So the opposite of hyperflexion would be opposite of flexion. Extension. Right, so hyperextension. So that's the exact opposite. It's your neck snapping back. Whiplash. This one is more common in rear end collisions. So if you're going and then someone rams you from behind, it's your body's still going forward, but your neck snaps back like that. And sometimes in car accidents, you can have both. You can have hyperextension and flexion. It's like you get rear-ended and then you stop suddenly and you jerk forward. So you can have back and forward, and that's not good. Next one is called axial loading or compression. So this would be, I don't know, like if something were to land on my head and like compress my spine down, like lots of weight kind of like pushing on it. I don't know in what kind of case that would happen. Maybe someone took a baseball bat and slammed my head, I don't know. So that's compression. The next one is rotational. So that would be, I kind of think of like when you go to the chiropractor and they take your neck and twist it. Obviously they know what they're doing. If, you've probably seen movies where they like the bad people like come up and take the neck and snap them by twisting them. So that would be a spinal cord injury from rotational. And then penetrating is the ones we talked about, like the bullets and knives, penetrating. And those are the only types. So hyperflexion, hyperextension, axial loading / compression, rotational, and penetrating. Which areas of the spine up here do you think are the most likely to sustain injury?
I'm guessing cervical.
Cervical, yeah, just because, well, your neck isn't as secure as like your trunk. Like when you stop suddenly, your neck is the most weak. Also, in addition to cervical, is lumbar, and that's because these are the two spots that have the most movement. So your neck has a lot of movement and your hips have a lot of movement, whereas like in the middle of your back, it doesn't really move as much. So these are the two that are most prone to injury just because of the movement it has. Okay, I'm gonna go ahead and erase this. Trying to get rid of some of the glare, but I don't think it's gonna work. All right, so let's talk about severity of spinal cord injuries, because they're not all made equal. So severity. So first one, you have complete. So that's pretty self-explanatory. Complete is where you have a complete loss of sensory and motor. So you can't feel anything and you can't move below the level of injury. So I have spinal cord injury C8, complete. I can't feel anything down here and I can't move it. So that's the worst. The next one is obviously incomplete. Right, that would make sense. Incomplete. This one is where you retain some sort of function. Usually it's sensory. So either it's not cut all the way through, or maybe it was just damaged, like not completely severed, or just like compressed somehow. So usually what you'll retain is usually sensory, being able to feel but not really able to move as much. And I've already talked about how the more higher up, the more severe. The other thing to note is that like in the acute phase of having a spinal cord injury, it's always going to be worse in the beginning, but you could potentially get better over time, depending on like what kind of injury it is. If it's a complete cut, obviously that's not going to get better. But if it was like maybe compression and now it's really just swollen and there's a lot of edema and like there's a bunch of fluid surrounding it, and like when you sprain your ankle, it gets really swollen and you lose a lot of function of your ankle because now it can't rotate, it's just kind of stuck. Same thing with the spinal cord. Like when you first had your injury, you know, people will be like, oh my gosh, I can't walk, I can't feel. But like as the swelling goes down, it begins to heal a little bit. Sometimes you'll regain back function. So you can't really always know right away like how bad the spinal cord injury is going to be. So I feel like that's probably something to put on the test is like, that's why we give steroids like methylprednisolone. It helps reduce the inflammation. And you want to give that within 8 hours of injury, if at all possible, to really get it in there quick to keep it from damaging. Because, you know, a bunch of swelling and edema can, like in and of itself, injure the spinal cord with pressure, right? So you can, you know, encourage patients, be like, hey, you know, we're trying to reduce the swelling. You might start to regain some stuff back. We don't know yet, right? When they ask, will I ever be able to walk again? They're like, well, we don't know. Something. Now, how would you expect to see, and like what order would you expect to see like some sensory or motor being regained?
Like up or down.
Mm-hmm. Do you think I'd be able to regain like movement up here first or movement down here first?
Down.
Yeah, so it starts down and heals its way up. So like one of the very first signs is like the anal wink. You know, you can see like the anal opening kind of like flex a little bit because that's the very lowest spot that's innervated. So as it starts healing, it'll work its way up. So we'll start there and then suddenly you'll be able to work this and then work this and it goes all the way up. So that's how you'll see regaining of function. Does that make sense? Yeah, I mean, when I was learning this in school, they're like, oh yeah, regain of anal length, and I'm like, but I didn't understand like why. I was like, well, it makes sense. That's literally the lowest. I know, like technically your legs are lower than your anus, hopefully, you know, but the spinal cord, like that's the bottom of it, and like the nerves kind of branch off. But anyways, I digress. All right, next we're gonna talk about some interventions. Okay, what do you do for patients that have spinal cord injuries, like, you know, while you're waiting for them to heal, or like what kind of things are you gonna have to do for them, like depending on if it's permanent, you know, because like I said, it could be temporary or permanent depending on the severity of the damage. Okay, so interventions. Oh, I need to find it. You know what? I'm going to try a different marker again. All right, so first one, yes, this works. Foley. Can you imagine or think about why that would be necessary?
Yeah, they're like the nerves that are going towards like the bladder or whatever, not working. So.
Yeah, so remember like when I drew the little spine at the very bottom with lumbar and sacral was bowel and bladder control. So if you lose that, you're not gonna be able to like really have the sensation that your bladder is full or be able to like pee on your own, right? So you'll either need to have a Foley while you're in the hospital, or what would you do like once you're well enough to go home? What would they do at home?
They could do like just an in and out cath.
Yeah, so intermittent straight cath. So typically they'll teach either a family member, or if you're fine, like, you know, you could do it yourself, whatever it is, depending. Same thing to go along with this, bladder scanning a patient. So Foley, I'm just gonna put SC for straight cath. I'm also gonna put bladder scan. While they're in the hospital, you wanna make sure, like if they're not on a Foley and they're just voiding, making sure that they're getting it all out, right? Because they could be dribbling a little bit, but retaining a lot, and then that's not good for the kidneys, right? So that's for bowel and bladder. Respiratory wise, what if they lose function of C3, 4, and 5? What do they lose? What do they lose? Diaphragm. C3 and 5 keeps the diaphragm alive. The diaphragm is what allows you to breathe, right? So if they can't move their diaphragm on their own, they're going to be put on a what? So vent. So they might need a vent. If they don't need a vent and they just, you know, let's say they only have lost T2 through T8, this innervates the intercostal muscles. So the muscles right around your ribs right here. So when I take a deep breath, what has to move? My intercostal muscles, right? So if these don't work, you can't take a deep breath. Right? So, and then what does that predispose you for? You can breathe, but just not deeply. What can start to build up in your lungs? Well, that, yeah, but I'm just thinking more like fluid, you know, like pneumonia, you know, because people taking really shallow breaths are not fully stretching the lungs. So it sets you up to get pneumonia. Or fluid buildup. And so for them, we want to really encourage turning, coughing, deep breathing, ICS, all of that stuff. Sense spirometer, I'm just going to put TCDB for turn, cough, deep breathe, if they're able to do that, right? Because if they, you know, taking deep breaths might not be something they're able to do. Now, what if we're talking about someone who's like a complete quadriplegic or paraplegic and they have little to no movement and they really can't turn themselves? What are we worried about?
DVT.
Yeah, that one too. So DVTs for sure, deep vein thromboses. So what can we do to prevent that? Yeah, so that would be more for like bed sores, but we'll get to that in a second. Yeah, so yeah, anticoagulants, you know, like Lovenox or whatever, to keep them from developing a blood clot. Also like TED-hose, right? TED-hose, SCDs, all that good stuff to prevent clots. You said turning, right? So turning wedges, you know, like those wedges in the hospital, like they're shaped like little triangles. This would be good for preventing bed sores, because if they can't move and they're sitting on their sacrum all day long, they're a prime candidate for getting that. They also have these things called rotary beds. Have you seen them? This is more helpful for like lungs, but like you have the patient lay down and it rocks them side to side. And so it helps kind of like move the the fluid around, and so it doesn't just build up and sit in one spot. It helps kind of like move it. And they also have in the hospital like fancy like air beds that kind of like constantly blow air, so it's constantly giving them movement and circulation to the area. So I've seen a spinal cord injury patient who has like a fancy air bed, and it's constantly like blowing certain places and releasing other places. So those are some things. What about let's see. Obviously in the acute phase, you want to give someone a C-collar, keep their neck still, right? So if you know what a C-collar is, that thing you wear to keep your neck from moving to prevent any further injury. When you roll a patient, you frequently have to roll someone. How do we want to roll them? Log roll. So that basically is just meaning like pretend their body is a stiff board, and you can't just like move the front half and then the lower half. You have to move them all together. That way it keeps the spine as much in alignment as possible. To go along with ICS, turn, cough, deep, breathe. Another one I forgot was, you've heard of CPT, chest physiotherapy. So you can do it manually, or they even have like machines to do it. Just kind of like manual CPT is basically just banging on their chest to help break the secretions. I also have like patients that you put a vest on and it gets hooked up to a machine that like shakes their vest. It goes just called a shaky vest. So those are good for respiratory. If they're older, or even if they're not older, and they're more susceptible to getting respiratory things like pneumonia because they can't expand their lungs, considering giving them like a flu or pneumonia vaccine to, just to make sure they're not, because they're gonna be more susceptible than like the average person, even if they're young and healthy. Just by the mere virtue they can't run around, they can't deep breathe, right? All right, and then some bowel interventions. These are bladder, but some bowel ones. Talked about this a little bit in traumatic brain injury, but with the bowel, you want to really try to get them like in a routine, because it's really hard to like, again, for them to feel it, and the movement, the peristalsis might be not working as well. So developing like a routine. So like all right, every day at 11 a.m. we're going to go try and have a bowel movement. So like gets their body kind of on a schedule. Not only that, but like increasing their fiber, so it makes it easier. Obviously you want to avoid foods that are going to cause constipation in these patients because they don't need that. I don't know if you've heard of rectal stimulation, where they like literally just digital stimulation to kind of wake up the nerves down there. And you can teach a family member or themselves how to do it. It makes it easier to go. And you can even do an abdominal massage. That's a real easy one. An abdominal massage will just literally help wake up the peristalsis, and kind of, you can even like push, because the colon goes this way and down, you can even like push in the direction that it's supposed to go, and it helps them go out. So those are some interventions you can do. Do all these make sense? I was looking at the PowerPoint, and like they were kind of like dispersed random places, like they weren't all together in one spot. So I kind of just put them all into one interventions list, rather than it like being under different sections. And then the other one, an intervention, I don't know if this is more of an intervention or like surgery. It kind of goes with both, but the halo traction, let me draw a picture. The halo traction is like, you got your person, right? Here's their neck and their arms. This is to keep their head like very still. So what they do is like they'll put like a band around the skull and like actually like drill it in, right? It kind of looks like Frankenstein a little bit. And then you've got like these bars that go straight down and hook onto like a vest that goes around their waist. So literally, like, does that make sense? Like it's literally they can't move their head like this or like this. It's just stuck in one position because it's literally keeping their head from moving. So this is called the halo traction because it looks like a halo, I guess. What do you think would be a very dangerous activity for this person to try to do if they're not able to look over their shoulder or look around? That's like a daily activity that people would want to do as an adult to get around. Driving. So telling someone they can't drive is kind of a big deal, but like if you can't, like, how do you just emerge? You know, if you can't look over your shoulder, you have to like look straight ahead. Driving's out of the question while you're in one of these, as long as with like swimming. And we want to be really challenging to try and swim, like keeping your whole body still. Like, you know, you might drown, but also like the pin sites. You know, these are a huge source of infection right here. Or not a source of infection, but a source of potential infection. And it's like, it's not just going into like your leg, it's going into your brain. So we kind of take that seriously. You know, we don't want to get meningitis or anything. So driving's out of the question, swimming's out of the question. I think showering, they said it's fine because you're not like leaving it submerged like for a long period of time. Usually shower, like it just kind of rinses off. So that's the difference there. And you're not like letting it sit in like a cesspool, because usually like when you go swimming in the pool, there's lots of nasty stuff in there and it's just kind of sitting and soaking it up. Versus a shower, it's like clean water and it doesn't stay. Okay, let's see what else. So that's pretty much it for the interventions. Tried to like cover every potential like complication. I don't know if there's any that didn't make sense. You had a question about it, or if there's anything I left out. If not, I'll go ahead and erase this. Good. So this kind of goes along. Maybe I should have done the complications first and then the interventions, but I don't guess it matters. We'll look at some of the potential complications with spinal cord injury, and they're pretty intuitive if you think about what the interventions are. You can probably list off some of them without even writing them down. So complications, we said laying around, DVT. More laying around, bed sores. And again, I'm not really going in order in the PowerPoint because they're kind of spread out really kind of in a different order. And I just thought it'd be easiest to just compact it into one. UTI. Why UTI? Yeah, so the urine's just sitting there. It's a source of breeding ground for bacteria. Not good. That's why we want a bladder scan or straight cath. We talked about ileus or compaction, right, with the bowels. What other complications are there? Oh, this one I didn't think of. So stomach ulcers. And it's okay if you can't, I couldn't think of why, but why do you think stomach ulcers would be a complication? I'll give you a hint related to this.
There's the movement of, I don't know, gastric secretion.
Yeah, so like your stomach is still producing stomach acid, right? But if it's not moving out, like obviously you don't want to just sit there indefinitely. But if it's blocked or like, you know, frozen down there, nothing's getting moved out, you're just gonna have a buildup sitting in your stomach of stomach acid, and that can burn a hole through, you know, your GI system. For stomach ulcers, one of the interventions I forgot to mention was, you know, GI prophylaxis. So putting them on like Protonics, Nexium, to prevent stomach ulcers and spinal cord injury patients. Other complications, acute kidney injury. Why do you think?
For blood movement through the body can stuff like onto.
Well, not so much blood flow, but it's related to the same reason for UTI. If it's not able to come out, what happens when the bladder gets full? Where does it go? Refluxes back up, right? So then it's bad when the urine backs up into the kidneys and overloads them. It can cause an acute kidney injury. So that's these two things are related. Also, kidney stones can happen. Now, the danger with kidney stones is that they might not feel it, right? Because like most people know when they have a kidney stone because it's one of the most painful things short of childbirth that I've heard, right? So if they don't feel it because their sensory is impaired, that's really bad, because when you have a kidney stone, it blocks the ureter, right? Like the pain is that you have this tiny little ureter and there's a blockage, and that's painful, right? So if they don't feel it, they don't know that there's a blockage, and so all the urine is still backing up and refluxing. So that's not good. Another complication, osteoporosis. Why do you think that is? kind of along the lines of this bed sores. It's kind of one of those, if you don't use it, you lose it. You know, like I don't know if you remember back in A&P, you have osteoblasts and osteoclasts. Osteoblasts are building up the bone and osteoclasts are breaking them down. And so like if you're not using your bones, your body's gonna start breaking them down. So it's like you're immobile, you're sitting around all day, your bones aren't getting stronger, they're getting weaker, right? So you can give patients medication to kind of prevent that, and they're called bisphosphonates. I don't know if you've heard of those. Bisphosphonates. And this is relevant because, and I don't remember, but there's a relationship between phosphorus and calcium and, you know, with bone health. And I can't remember if phosphorus makes the bones weaker because there's phosphorus in soda, and soda is bad for your bones. So bisphosphonates probably are the ones that reduce the phosphorus to keep your bones from breaking down, if I remember correctly. Don't quote me. But yeah, so it's a disuse problem. And you'll notice that all of these so far have to do with either a loss of sensory or motor, right? DVT has to do with a loss of motor. Bed sores has to do with both. Like you can't feel, you know, like when you get uncomfortable from sitting in one position, you move. Well, they don't feel it and they can't move anyway. So this is a result of both sensory and motor. They can't tell their bladder is full and they can't do anything about it. This is a loss of movement, loss of movement, or motor, I should say. And then the last two, contractures. Do you know what those are? Yeah, so it's an odd thing. So like when your muscles start to, you know, flexibility is really important. Like the more you are flexible, the better, you know, range of motion you have. So you maintain flexibility by using your muscles, right? So like my muscles are relaxed right now. That's what allows my arm to be straight. But as you don't use your muscles, they shorten. And like this is what happens when your muscle shortens. Like it starts to contract, you know, so it gets smaller and smaller because you're not using them. And so like I've seen a lot of patients that like they're stuck in this position because their muscles aren't used. They don't, like their muscles are just shortening and shrinking. So like contractures are like when they go like this, or like you can see like their legs kind of do the same thing. So to avoid that, you know, you can do passive range of motion exercises on your patients. So obviously they can't move their own arms. So you take their arms and move it for them. Like that just helps keep their muscles flexible so they don't end up like this, you know. You can also use splints or braces to keep their arms, like I've seen like arm splints keep their arms straight instead of allowing them to curl in, or AFOs. Do you know what AFOs are? I forget what they stand for, but I see them all the time. They're like these hard plastic shoes kind of that like you put your whole, it goes up to here and it goes down your foot and it like is in a sharp like right angle, and like you put your foot in it and it keeps your foot like stretched and flexed so that it doesn't like drop. Do you like the foot drop, you know? So it helps keep like their feet straight. So those are some more interventions, braces and splints and things like that. And then the last one, the last complication would be sexual. So like erectile dysfunction, right? Because that has to do with sensory. You can't feel anything. If you don't feel anything, nothing's going to happen, right? And then also, you know, women that have a spinal cord injury, they can still get pregnant, right? There's nothing to prevent them from getting pregnant just because you have a spinal cord injury. So what kind of potential problem does that cause when you're trying to give birth and you have no ability to push, right?
Yeah.
So what do you think they have to do?
C-section.
Right. So C-sections are just, they have to, because you can't push. So C-section if you get pregnant. So those are some potential complications. So there's several. You can take a picture of it if you like. Do you have any questions on any of these? Or do those make sense?
Makes sense. Yeah.
I'll go ahead and erase those then. Now we're getting to the fun stuff. And by fun, I mean complicated. That was all pretty straightforward, I think. Now, the last bit of notes have to do with spinal shock, neurogenic shock, and autonomic dysreflexia. So that's the rest of the whole topic. And it was hard for me looking over it when I was like a student, and I was like, I don't understand what the difference is or what any of this is. So we're going to go through it and hopefully it'll make sense to you. So we'll start with spinal shock. It's the easiest. Spinal shock. Okay, so this one is temporary and complete. What does it mean when it's complete?
Like it's severed, the cord is severed.
So you lose
Like,
both sensory and motor, right? So both are gone. And this can last for days or weeks until it heals or the edema goes down or the swelling goes down or whatever, what have you, right? So signs and symptoms of this, I mean, some of them are pretty obvious, is flaccid paralysis, and that's pretty, you know, you'd expect that. Obviously, reduced sensation, so they can't feel anything. These are kind of duh. Do you know what deep tendon reflexes are?
yeah, well, we can go over it again.
So deep tendon, that's DTR, deep tendon reflexes. You know, like when you go to the doctor and they take out the little hammer and they bang your knee and make you go like that. Well, if you have someone with spinal shock, they don't have that reflex because they don't feel it, right? And they don't have the ability to have motor. So, you know, they can test all sorts of reflexes. There's actually several. The knee isn't the only one. There's like ones in the elbows and all over the place. They don't have any, no reflexes whatsoever. They also will have loss of bowel and bladder, right? So everything that we talked about, like compaction, ileus, and full bladder, and all those things that go with that, with, you know, potential UTI, potential whatever, you want to be looking out for, right? Yeah, and then I said you can tell when they're starting to come out of it, when they're starting to heal, because what will be the return sign? Right, so anal wink, that's the big one. That's like the thing that they want you to know. I think there's also there's the penile wink too. It's called the bulbocavernosus. Yeah. So just like the anal wink can happen, you can have the penile opening wink too. But if you're a girl, you don't have that. So anal wink. Everyone has one, unless you have an ostomy. Then you don't. Well, I guess you still would have an anus. Anyways, doesn't matter. Everyone gets an anus. Okay, so this one's pretty straightforward, right?
Yeah.
That's pretty much it. Is there anything else on there that I didn't cover?
They can't sweat.
Can't sweat. Yeah, sure. I guess you can't feel that you're hot, so your body's not gonna make you feel cold because you can't feel it. Yeah, and then we kind of already talked about interventions. So like there was interventions for like several different things, and I just lumped them all together to make it easy because it's kind of all the same. Spinal cord injury intervention is a spinal cord intervention. So, all right, now we get to the two that are often confused: is the neurogenic shock and the autonomic dysreflexia. So I'll start with neurogenic shock first. Neurogenic shock. So this one is where you lose the ability. Okay, well, do you remember in ANP the parasympathetic nervous system and the sympathetic nervous system? The sympathetic is the fight or flight, and the parasympathetic is rest and digest, right? So with the neurogenic shock is that you lose the sympathetic nervous system. So you lose SNS. So usually, you know, to maintain equilibrium and happiness in your body, your sympathetic nervous system works hand in hand with your parasympathetic nervous system to work together and find a happy balance, right? So if you lose the SNS, then that means your parasympathetic or your PNS is unopposed, right? So it's just running and there's nothing to like keep it in check. Does that make sense? So PNS, unopposed. You with me so far? So that means that like your vital signs are going to reflect a parasympathetic activation instead of a sympathetic activation. So in fight or flight or SNS, you see like your heart rate go up, you know, like everything goes up. Your heart rate, your blood pressure, your breathing, because you're like running from a bear, right? So the opposite is the PNS. So signs and symptoms. What do you think you're going to see? What's heart rate going to do?
Decrease.
Heart rate's going to go down. What about blood pressure?
Down.
Yeah, I mean, that's pretty much it. Cardiac output is going to go down. So that would lead to poor perfusion, right? So like if you're not having good perfusion, what's that going to make your extremities temperature? Right, so temperature dysregulation problems. So people like this, you want to like keep track of their temperature, make sure they're getting good perfusion, check their pulses, because all of this is going to be down. And when I say down, I mean like really down. Like their heart rate can like be in like the 40s, right? Their blood pressure, like systolic, the upper number can be in the 70s, right? So like not optimal for sustained living, right? Not great. I mean, athletes can live with this, but your average person needs more than 40 beats per minute. So this is neurogenic shock. Okay, so the rest and digest just gets out of hand. Does that make sense? Okay, so for interventions, what do you think we can do to kind of fix some of these problems? Put on your nursing thinking hat.
Give fluids.
Perfect. So fluids will help the blood pressure, right? So IV fluids. What else?
Vasopressors.
Vasopressors to try and increase the blood pressure, right? So like vasopressin, dopamine, dobutamine. I'll just write those down. Dopamine. Someone once told me that they like it when I write it down instead of just say it because I see it and remember it. So I'm like, okay. Dobutamine. Those are vasopressors. Now, okay, what you're going to give first though? Are you going to give the patient, oh no, their blood pressure is bad, I'm going to start with meds, or oh no, their blood pressure is bad, I'm going to start with fluids? Which ones do you start with first? Fluids first, and here's why. If the blood pressure is low, right, it's going to be easy to put fluids in because you're not having to meet much resistance, right? Like the tube or the arteries or whatever that you're putting the stuff into are relaxed, so it's easy to like put something into it. If you increase the blood pressure first and then try to put fluids in, it's like tighter and squeezed, it's squeezed tighter, and like the pressure, you're trying to overcome more pressure now to get something in. So it's like, okay, start with fluids, and once the fluids are in, then give them vasopressors. Does that make sense? So fluids before pressors. I'll just put 1, 2. What else? Yeah. So this is, for blood pressure, right? Now for heart rate, you've got atropine and what did I say? Atropine. You can also do pacing, like a pacemaker, to just force their heart to have more beats, right? That obviously probably is going to take longer because you have to like have that put in versus you can just give someone atropine real quick. But if it's like a constant ongoing problem, maybe they will do that. I don't really know what goes into the decision making because that's not my job. I don't get paid those dollars to do that. Body temperature management, so blankets or ice packs, depending on whatever it may be. And then lastly, we want to put on, like, for their legs, might want to put like SCDs or TED hose or ACE wraps. I'm just going to put compression. And the reason being, you want to try and squish any blood that's in the periphery and squeeze it back into the central circulation. Because again, we have the heart rate and blood pressure problems. So you want to keep those organs well perfused. Does that make sense? Yeah. Okay, so does this make sense? So if you're looking at spinal shock and neurogenic shock, and they're talking about signs and symptoms, and they're talking about vital signs being weird, notice all this is vital signs, it's neurogenic. Spinal shock has nothing to do with vital signs, right? Everything, their vital signs should be fine. It's just that they don't feel anything and they can't move, right? So just typical kind of spinal cord injury, right? If their heart rate and blood pressure are all over, like super low and problematic, it's neurogenic, okay? Now we're gonna look at autonomic dysreflexia, which is gonna like look similar but be different, and it might be confusing which is which. So I'm going to erase the interventions because that makes sense, but I'm going to leave the signs and symptoms up and draw it right next to it so we can compare. I always got these two mixed up, the autonomic dysreflexia and the neurogenic shock. So we're going to go over it. Okay, so I'm just going to put AD for autonomic dysreflexia because I don't feel like writing that. Yeah. Okay, so in the term, in the name itself, it says autonomic. And we know that the SNS and the PNS are both branches of the autonomic nervous system, right? Because it happens automatically. Automatic. Like you don't think, I'm going to activate my heart rate right now. Like it just happens. So the autonomic nervous system is both of these. And then dysreflexia, dys is like, bad, like discord, or, something, if you put dys in front of it, it's like bad. So like basically what they're saying is the autonomic nervous systems aren't communicating well. So there's like dysfunction between the two nervous systems. So you have the PNS and the SNS kind of firing at different points in the body, and they're not communicating, right? So this one is complete loss of the sympathetic. So all you have is the parasympathetic activated, whereas in this one, they're both activated, but in different ways in different places. Does that make sense? Now, what it's going to look like functionally is an overstimulation of the SNS below the injury. So, and then I'll show you a little diagram when we should make more sense. So this one, you lose the sympathetic. This one's an overstimulation of the sympathetic below the injury. I'm gonna draw a little picture, make it make more sense. So here's man. So one of the other things that, if you go back to A&P, helps make things make more sense, because you don't really realize how it plays out when it comes to nursing. You haven't done it yet. But the parasympathetic like fibers are located in the brain up here. So this is where the parasympathetic is located. And then the sympathetic is like below, right? So let's say your point of injury, where you had your spinal cord injury, is like right here, right where this blue X is. Typically what you'll see this one is if they have an injury at T6 or above. Typically you won't see autonomic dysreflexia if it's below T6. So I'm going to say T6 and up is where you'll see this happen. You with me so far? So when it comes to blood vessels and things, which one, parasympathetic or sympathetic nervous system, has to do with dilation? Parasympathetic. So dilation is going to be happening up here, and constriction is going to be happening up here. And I'll explain why in a second. Okay, so I'm going to erase this because I don't think you need the symptoms. You just need to know that you lose SNS. So what happens is, I'm going to draw another picture. It's going to be very beautiful. Okay, so this is, let's say, their bladder right here. Okay, this is their brain, and this is the spinal cord going straight down. Okay, so what happens here with autonomic dysreflexia is that something triggers it, right? Some kind of stimulation is going to trigger this response. Now, it's some sort of stimulation that occurs. It can be like really, really loud noises. It can be like a lot of stimulation happening with lights and visitors. It can be like really uncomfortable bed sheets that you're laying on. It can be a full bladder, right? So something is stimulating the patient, and it's going to trigger an autonomic dysreflexia syndrome. Does that make sense? So typically a common one is a full bladder that will, like, that feeling, it kind of hurts, you know, when you really have to pee and like it's sending a signal. So let's say the bladder is full, right? Now this is sending signals. Oh, I forgot to draw the area of injury. They have an injury at T6 and above. Okay, so it's severed right there. Now your bladder is full, so it wants to send a message up up the spinal cord. Remember, we talked about sensory is afferent or is ascending, but it can't because it's severed right here, right? So it can't reach the brain. So what happens is it sends the signal elsewhere, like through a different nerve. You know how like there's branches of nerves that come off. So it signals to the arteries and vessels, hey, problem, and these constrict, right? Because this is the sympathetic nervous system below. So these are going to constrict because it's below the head. Does that make sense? So now what's your blood pressure going to look like? So increased blood pressure, right? You with me so far? Now, in your vessels, you have these things called baroreceptors. You know what those are? You've heard like barometric pressure. It measures like the pressure in the atmosphere or whatever. So you've got these little baroreceptors in your vessels that sense like how the pressure is doing in your arteries and stuff. And that message gets sent to the brain so that your brain is like, hey, do we need to reduce the blood pressure? Do we need to increase it? Do we need to set off the Ross system? You know, all of that. So the baroreceptors sense that the blood pressure is going up really bad, right? And it goes to the brain to tell it, hey, blood pressure is going up. So the brain's like, okay, we'll fix this. We'll send an impulse down to go fix the source of the problem. Oh, wait, we can't because it's severed right here. So it can't go down, right? So it goes out another way, just kind of like it did down there, goes to the heart because the heart can still, it's more up, I guess. And this one, they're going to tell the heart rate to go down, right? And this is activated by the PNS because that's the brain signals the heart. Does that make sense? So you have like the bottom half is sympathetic and the top half is parasympathetic. And so you're like, I don't understand. The blood pressure is super high, but the heart rate's super low. I'm confused. Are they having autonomic dysreflexia or neurogenic shock, right? So you see how like at the scene of injury, it splits into two. So there's sympathetic below and the parasympathetic above. Does that make sense?
Yeah.
So signs and symptoms, where can I write signs and symptoms? Can I squeeze it right here? Signs and symptoms, blood pressure is going to go which direction? Up. Heart rate is going to go which way? Down. And so that looks confusing because we know in the neurogenic, everything was down, right? Because you lose the sympathetic, so all you have is parasympathetic. So if they're giving you like patient signs and symptoms to try and get you to figure out what's going wrong with them and what intervention you might do, if they're disagreeing like this, where one's up and one's down, it's autonomic dysreflexia because there's dysfunction between the autonomic nervous system. Does that make sense? If everything's just down, everything agrees, it's the neurogenic where they've lost the sympathetic. Does that make sense? Yeah. So some more signs and symptoms. Another one is headache. Now, why do you think that they would have headache by looking at this picture? Yeah, so you know how you like when you give nitro, it gives a nitro headache. Why? Because it causes vasodilation in the head, right? So all the blood is rushing to the head. I don't know if you've ever been upside down for any length of time, like hanging from monkey bars or something, and it kind of makes your head hurt. You know what I'm talking about? So you're having massive dilation in your head because this is the PNS zone. So there's gonna be vasodilation, it gives you a headache. Some other signs and symptoms, nasal congestion. What do you think that's related to? Again, it's just the dilation. So like the what do you call these? Vessels in the nose are going to expand and there's going to be more fluid in the nose. Because your nose is part of your head, right? So like you've got massive vasodilation, rush of fluid, rush of blood. Now your nose is going to be stuffy. It's going to be harder to breathe. Does that make sense? Facial flushing. Face flushing. Again, having to do with dilation, blood rushing to the cheeks. Does that make sense? Yeah. So when I was, taught this, I just memorized a bunch of signs and symptoms, not really understanding that this was why. This part wasn't explained to me, the dilation constriction part. So let's see. All right, so their face is flushing up here. What about their extremities down here? What do you think their extremities down there are going to look like with their skin?
Pale.
Exact opposite, right? So cold, clammy, and goosebumps on the lower extremities. So I'm going to put cold, bilateral lower extremities. Does that kind of make sense? How you see all these conflicting signs and symptoms? Like, wait, they're face flushing, but cold goosebumps in their legs. The autonomic nervous systems aren't being able to communicate because of the severing. And then the last one is nausea. And this is just related to the activation of the PNS, the rest and digest bit. So that's the nausea. Does that make sense? So the interventions for autonomic dysreflexia are going to look different than the interventions for neurogenic shock, right? You with me?
Yeah.
So I know in like you guys' tests, they don't tell you your patient has neurogenic shock. What are you going to do? Right? They'll be like, patient Smith comes to the emergency room with elevated heart rate or whatever, elevated blood pressure, decreased heart rate, facial flushing. You have to like figure out what it is and then figure out what to do, right? So they're not going to just tell you. So some interventions are going to be geared towards fixing these problems, which are slightly different than the neurogenic problems, right? Because you got all kinds of weird stuff happening. This is the weird one, right? This is the weird one that everyone like struggles with. So the first thing you're going to do is sit the patient up. Now, why do you think you're going to want to sit them up? If possible, obviously, if they're in a back, if they have a broken back somewhere and you can't sit them up, then maybe don't do that. But like, if possible, sit them up. Why do you think? You're laying down.
Oh,
Where's the blood more go to?
more pressure.
More blood to the brain, right? And not only does that cause headache, but what can it potentially cause if enough blood and pressure goes to the brain? Yeah, an aneurysm, a hemorrhagic stroke, right? If so much blood is rushing up there and the pressure gets so intense, they can burst the blood vessels and have a stroke. So they don't need that on top of a spinal cord injury, right? So you want to sit them up. It'll help. The gravity will help drain some of that blood out and go down to the periphery where they need it because their extremities are cold, right? The second thing is try to identify and remove whatever the stimulus is. So like if they're laying on like a call light, for example, and you're like, oh, well, that's probably uncomfortable, remove that, bladder scan them, see if it's their bladder that's full. I don't know, like check to see if they haven't pooped in a long time, they're compacted or something, just try to figure out what the stimulus is and get rid of it to bring them back down, right? Because it's the stimulus that triggered this whole response, right? Remember, like in the example I gave, it was just a full bladder, but it doesn't have to be a full bladder. It could have been whatever, but this is just easy to draw. And it triggered, because when you're in pain, usually your blood pressure goes up. So it stimulates that in the whole cycle. So if you get rid of the trigger, this will subside, right? So remove the stimulus, straight cath them maybe, who knows. And then you're going to monitor their vital signs every couple minutes. So like every 2 to 5 minutes, because their blood pressure could keep rising, right? And if their blood pressure is getting to like the 200s, they're at risk for stroking, right? So monitoring their blood pressures until the problem is resolved. And if, if you're trying to remove the stimulus and you can't figure out what it is and their blood pressure is getting dangerously high, what do you want to give them? Something to reduce the blood pressure, right? So like hydralazine or nitro or whatever it is, to get that blood pressure out of a dangerous zone into a more safe zone. Does that make sense? Did this make sense? Do you have any questions about the two that was kind of like not clear?
It makes more sense now.
Oh yeah, I know it made no sense when I first heard it. I was like, I don't understand. But yeah, neurogenic shock, the symptoms will all kind of agree, you know what I mean? Like it'll all look parasympathetic, low blood pressure, low heart rate. They all kind of will agree. There'll be poor perfusion, which you would expect. With autonomic dysreflexia, they're a hot mess, right? Parasympathetic up top, sympathetic below. If that helps you, you just think para up here, sympathetic down here, dilation up here, constriction down here, hot, cold, high, low, anyways. And it's really just because the signals can't communicate, so they have to like go around and all over the place. There's no communication there. The bridge is broken. Do all these signs and symptoms make sense?
Yeah, so the heart rate is low. The blood pressure is high, like everywhere, not just like below.
Yeah, I mean, even normally, like, you know, there's a line here, like,
Yeah.
you know, the blood pressure is kind of its own thing below, and like what's going on in the head is, you know, like with ICP, you want to increase the blood pressure to help get up to the brain. So like typically there's like two separate systems anyways, but the brain's trying to reduce the blood pressure, but it can't like it can't like go the normal channels. So the heart rate tries to compensate by going down. You know, if you like know the compensatory mechanisms and how those try to like help each other, usually end up making things worse. That's one of those. So they can't really fix it. So they're like, okay, heart rate's going to go down because the blood pressure is going up, and they just can't communicate very well. So you've got, you know, parasympathetic activation above the injury. So like if I had a spinal cord injury at T6, which I said was, you know, T6 and above is where you'll have this happen. You won't have it, like if you have a lumbar, you won't have autonomic dysflexia. It has to be T6 or higher. So, you know, if I have, you know, T6 injury, above that's going to be parasympathetic, below that's going to be sympathetic. Does that make sense? Yeah, I thought you might want to just take a picture of my clean looking notes, because that looks more, just take a picture of the page. That's cleaner, it makes more sense. Thank you. Think we're good on this topic, or is there anything else on the PowerPoint that I didn't explain? Trying to get this all on. Oh, I know. I can do this. Can you see that possibly? Maybe you can push pause and look at this. Okay. All right. Well, I'm going to stop the video.